I'm a pediatric emergency medicine physician in Atlanta, and I'll be moderating the last session. So I'd like to invite Dr. Joseph Boney up. I'm not going to go through his introduction again because he was introduced this morning. So come on up. Thank you.
Right, good afternoon, everyone. I have the honor of taking the first slot right after lunch. So bear with us, let's try and get through this presentation, and it's a few more before we come to the end of the conference. So congratulations to everybody. So this afternoon, I had a topic that I had to Google what the first one was, glocalization, and on the schedule you'd realize that Ben Wachera was supposed to speak before me, so my hope was that he would spend a lot of time explaining what this is, but unfortunately we had to switch that around. Ooh. One sec. All right. So among all the specialties among emergency medicine, we have come to realize that disaster medicine is one that innately we all end up doing some of at some period in time. If we try and hide from it, everybody will know that they still were involved in COVID-19 management. And whether you like it or not, there's a huge component of disaster medicine that we were all doing during that time, especially response. And disasters happen everywhere. So I'll try and define what a disaster is in simple pictorial terms. So we have one miner in an underground pit, so let's give him a helmet to make sure he's safe. And a few rocks fall on this miner. At this point, the expectation is that the local hospital, the local clinic should be able to manage with the resources that they have. But if it's an entire mining crew of 30, 40 people who are trapped underground because a pile of rocks fell on them or an explosion that didn't go right, then you would have a situation where you will need extra resources, probably outside the scope of the local hospital or the local organization to be able to manage them. So the definition then stems from any serious distraction occurring over a short or long-term period, which causes widespread human, material, economic, and environmental loss that exceeds the ability of the affected community to be able to cope with its own resources. You can replace this community with anything that fits within that scope. So the hospital, the clinic, the region, and at some point it was the world not being able to cope with it in terms of COVID-19. This table then just shows you what kind of hazards we can have that can escalate to become a disaster, and which kind of impacts that we have. Fires, explosions, natural hazards, terrorism, mechanical breakdowns, cyber attacks, and so on. And the assets at risk will be from the people all the way down to the environment, meaning that disaster medicine will affect, a disaster will affect one system or the other, and eventually cascade to affect other systems within the scope, with the impacts being casualties, business loss, loss of confidence in organizations, lawsuits, and so on. So the aim of a course, or the aim of you learning about disaster medicine, is to train individuals to be able to respond. Design a system that will be able to probably put you at balance between the disaster and your capability, and eventually maybe be able to have enough resources that you don't have any disasters anymore. Your capabilities are enough to surmount the disasters that can come up. Still with the background of what disaster medicine looks like, and you cannot give a disaster medicine lecture without showing the disaster cycle for disaster management. And this gives us a scope of where we are and where we can be placed in this. So just briefly, the mitigation looks at how you minimize the negative effects of the disaster. So before it happens, what are the risks? How do you reduce those risks entirely? One, to prevent it from happening, and if it happens, reduce the impact. As much as we know we cannot remove every risk, then we would go to preparation, where we organize ourselves to be able to respond if there is an event. Response is what most of us end up being in, so the medical response of a disaster, and then eventually coming back to the normal is what our recovery is. So whether it's natural, man-made, in Africa, it seems to have a different focus, because not only do you have to deal with it, but you have to deal with the diversity of cultures, diversity of economies, and the strength of the healthcare system, which might probably not be as strong in some areas or in some countries. So in some countries, they're constantly at surge or constantly in a disaster phase, and whenever they have anything else, it really puts the health system in a lot of risk. Typically, a lot of the tools that we have been tailor-made at a global level. Nobody thought about economic variations, not in a country, but even within a country, between a city and a 15 minutes drive to a peri-urban place, how that policy might not work. And so the best results is looking at having local solutions to the disasters that we have, even when we have global policies. An example is Ebola. The World Health Organization, MSF, CDC drew wonderful programs, but they did not factor in the deep-rooted traditional burial practices. So no matter the programs they brought, until the point where local leaders, traditional healers, respected cultural leaders came together to modify it, it wasn't getting the results that was needed. So globalization, which is a merge of globalization and localization, means that you have your integrated international policies, but how do you adapt them for them to be functional within your context? Examples are widespread for COVID-19. Every country picked strategies that will work for them, following what looked like on the disaster management cycle. But COVID broke this. The disaster cycle was all over the place. Preparation was based on previous knowledge of COVID-19, which was very little. Nobody had seen COVID on such a marked scale. It didn't even have the name COVID. It had one of the SARS, but hadn't been seen on such a large scale. So preparations were based on the previous knowledge, which did not make people enough prepared for it. The events initially did not get the full attention. So it's something happening in China, let's leave it in China, and let's not worry about it till it was too late. Then we had a response that was worldwide. Usually when people will draw a plan, they will say, if my hospital is unable to do it, I will go to the next advanced hospital, I'll go to the next advanced country, I'll go to the neighboring country for assistance. But now everybody was trying to use the little resources, and we're not ready to, and did not have the capacity to support people, especially at the beginning of the global pandemic. And if we talk about recovery, there are still lots of countries that are still recovering from COVID. And the mitigation strategies of vaccines were hampered by people that decided we won't take vaccines, and even after a bit, people not taking boosters after they had taken the initial doses. But we have examples of when people modified global approaches into local ones, and then they worked. One example is, during the COVID-19, Ghana used the community health-based nurses, which is a CHIPS compound, who knew exactly where people stayed because they're in the community with them, and they managed to do contact tracing without having to move around and the risk of getting infected. They could tell these number of people are usually the ones we meet in this house, and if they're all here, this accounts for this number of people. And if one person is infected, they could tell which household they will encourage the rest to get tested. In Rwanda, the use of drones were used to supply medical supplies especially during the period of COVID. It was used to transport samples and give medications, vaccines to places that were a little hard to reach. During the cyclones in Mozambique, Zambia, Malawi, local initiatives helped to demonstrate that the local knowledge of disaster preparedness was really crucial. People found local ways of sending warning signals for people to be prepared against bad weather. And similarly, in 2023, Morocco highlights that the rescue teams needed the local people to help them maneuver the hard terrains that were in that system. So the key component of localization of disaster medicine is adaptation of global protocols. So you find it, you look at the standards that are there, maintain the standards, but adapt them for what will work in your system. And this has been really championed by the WHO Emergency Medical Teams Project, which looks at systems that are in-country, professionals that are in-country, who train at international levels and form emergency medical team which can respond in-country and out of country. If you're here and you're involved in policies and your ministries and you do not have an EMT team, I think this is something you should look into, because this is starting to become the in thing where you can have teams that are well trained in your country and can respond in country, but also support regionally and globally. The World Association for Disaster and Emergency Medicine is also another group that has been developing global protocols, but are very sensitive for it to be culturally, economically, and regionally adapted. I will spend a lot more time because I can see a lot of people here who can go into disaster medicine and disaster fields to speak about strengthening our capacity. There are many training programs that are short-term, long-term, and this is only a snapshot of some of the programs that are there. But some of the programs I concentrate on now are the ones that you can do from the African continent. You do not need to spend lots of time moving. You do not need to get qualifications outside the country, but you can do it right from here. And an example is this program, the European Masters for Disaster Medicine, offered purely online with only 2 weeks to be spent outside the country in Italy, but gives you a real depth of world-class experts teaching you disaster medicine, online simulations, and so on. From that same program, have they also developed a Master of Science in Disaster and Health Crisis Management, which also allows people to do remote. There's a PhD program which accepts candidates from all around the world. Unfortunately, doing this remote is a little more difficult than the master's program. Short courses have also become the thing. If you do not have a year to spare and it's only a matter of days that you have, there are these lists of short courses that are available to help promote the capacity building for disaster medicine. The AEMS, which stands for Analyze, Emergency Operating Plans, Mapping, and Simulation, is a unique program for multidisciplinary approach, and this was developed in Ghana but has been run in several other countries. And the course is just 5 days, and it helps to build a skill in disaster medicine. And at the 5th day, you run a live simulation in your hospital using your resources so that you understand how you can actually man a mass casualty event in your facility. The model teaches you about disaster medicine cycles, surge capacity, mass casualty, and so on. And anybody in the health sector can attend, including our security agencies, fire service, and so on. From the idea of the cycle being huge and you not responsible for every part of this cycle, the Kenyan Emergency Medicine Foundation have looked at developing a program which is targeted at the clinician. What happens when they bring you 30 patients to your doorstep? So these programs have been designed, and they're going to be probably more developed and spread across Kenya and the rest of the African continent. The WHO has also designed a mass casualty preparedness toolkit. You can start doing this on the WHO Academy, and there are in-person courses that are associated with this. And I'm proud to say AFEM has had a training for over 28 people who are trainers across the continent, and we'll be happy to promote this in any country that continues to run this. A one-day course, which is called the Major Incident Management in Africa, which gives you enough information to be able to start off as a disaster response person in your institution. And then adjunct programs such as this. If we talk about fellowships, all the fellowships that we can see here require you to get a USMLE before you're able to do this. If this is a path that is possible, we hope you will take this path and hopefully come back and come and do the disaster medicine in Africa. But there's also a program which is more public health focused by the African CDC. But in my search and continue to search, I did not find any fellowship programs in disaster medicine in the African continent. I might have missed it, so if you know about one, let us know. And if you don't know about one, why are we starting one in the places that we're teaching and we're instructing? This program is, however, one unique program by SUNY Downstate in New York, which allows you to do your fellowship remote, and you still get a full fellowship at the end of a year when you submit a project. Other approaches that will help with localization of disaster medicine includes supply chain and resource management. Might not be for us, but we should know about it and teach our people that we work with that if there's a disaster, you cannot pick a protocol, but you need to adapt it. Technology and innovation, policy and governance. A few of these challenges, as we continue to talk, has been springing up. So the cultural sensitivities, resource constraints, and coordination and communication. And some of the strategies will be, let's link up with the global agencies. What are you doing? Make sure that whilst we're developing this, we have all levels of staff, all regions, all groups there to help with the development. Capacity building, as we have spoken about, community engagement, and integrating research into this. So with this, would like to invite you to a new idea which is being birthed right at this conference. It has been in thoughts for many years, but Disaster Afrique, which is looking at a community that we will build to help people who are barely just interested in disaster medicine all the way to the experts, to be able to have a common ground, share resources on one web page, have forums, have an opportunity to organize webinars. And the aim is to empower healthcare workers, emergency responders, and researchers to be able to have a venue to be able to get enough information for emergency care. We're hoping that we can have all of you join this call, and we will be reaching out through the Same Qualities Network to be able to send all of you emails once this website is up, so that you're able to sign your institutions up to contribute to this and help build this. With this, I say thank you very much and have a wonderful afternoon. Not sure, are we taking questions right after?
Thank you, Dr. Boney. That was really interesting. And being somebody who's interested in preparedness myself, I think it is really important thinking about the local adaptation about all of these different issues, because it is definitely not one size fits all. So thank you for that lecture. Okay, I'd like to next introduce Professor Ben Wachira. So he's a distinguished assistant professor of emergency medicine with a deep commitment to improving emergency care. Skip it? Okay. All right. You can say what you'd like to say from it.
Thank you. Okay. Let me save you the trouble. Hi everyone. I'm Ben. That's simple. All right. Welcome to this talk that Mabula forced me to do. Keyword being forced, but was quite eye-opening. So like we're gonna do drugs for the next 10, 15 minutes, and it's gonna be exciting. Yeah, I was learning a lot looking at the topic. I didn't even know the stuff called new psychoactive substances. Yes. And Kenya features prominently in some of these discussions where I'm from. All right, so thanks, Joe, for telling us what glocalization is. Again, another word Mabula came up with. And the good thing about this topic is we are all in the dark, whether you're in Africa, in the US. I know a lot of people have testing for this stuff. But the good thing is it's probably stuff you've seen before, just have fancy names. So for those who are old, let me not say use old, well seasoned in the profession, I think we were used to the common drugs, cocaine, heroin, weed, and all the other stuff that was that we knew about. And then came very fancy chemistry. I think it's after that, what was that? There was that show, what was it called? The show of drugs. Sorry, Breaking Bad, yes. So a few Breaking Bad people came up with a whole new set of drugs that, just a show of hands, who has seen this synthetic stuff? I'm sure in the US, you guys, again, but yes, US, I guess it comes from there, then comes to us, but all good, yes. So it's synthetic substances designed to mimic the effects of existing illicit drugs, and essentially why they had to come up with these drugs was because, of course, the cops became brighter, cleverer. They got all this dog sniffing stuff. So they decided to create chemical compounds that do the same work, but essentially avoid being caught by the cops. Which I guess is genius, but also not quite good for what we see in the emergency department. So there's a whole website, like there's United Nations Office of Drugs and Crime has this whole website dedicated to these new psychoactive substances, and there are like what, this is 1, 2, 3, there's 6 different categories. So this is the chemical structures. So they're like 9 different chemical structures. So those who are keen on chemistry, there's amino-diodanes. Those in residency, maybe they will ask you to draw structures of this stuff. I remember we used to be asked to do that. There's synthetic cannabinoids, tryptamines, synthetic cathinones. I think that's your bath salts or something like that. But essentially, in terms of the clinical presentation, you pretty much have these 6 kind of presentations. So you have your opioids, which pretty much mimic your morphine-like effects. You have your synthetic cannabinoid receptor agonists, which mimics your weed effects. You have dissociatives, which pretty much mimic your PCPs and similar drugs. You have the hallucinogens, classic hallucinogens, LSD, DMT, and you have sedative hypnotics, which mimic your benzos, pretty much. And then you have your stimulants, which mimic your methamphetamines and ecstasy. So there's what we know, then there's these new substances that mimic, and the interesting part of it is, well, so as you can see the percentage in terms of how common they are. As you can see, the majority pretty much are your stimulants and your synthetic cannabinoid receptor antagonists. I think when they started making weed legal, then that got quite creative. So at least 60% of what you'll probably see in your emergency department will probably either be stimulants or your synthetic cannabinoid receptor antagonists. Not antagonists. Yeah, it's the funny part. Like, so this is prevalence of people who inject drugs among the general population, age 15 to 64. There's a dot there that was quite prominent. I was like, Kenya features significantly. I don't know whether that's why Mabula asked me to do it, but no. All right, but in Africa, the problem exists mainly South Africa, Kenya. I don't know why they left out Nigeria in this color, but again, this is 2011. But Kenya, South Africa, and Nigeria are quite prominent to have these MPSs, though I did see some articles from Tanzania, so it's something that's also starting to affect Tanzania. But those are the countries where this stuff is really going, global. and that gets the localization. And they're also available on the internet. Yes, so, and they have really cool names. So you can buy Chupa Chups, and that's not the sweets you give your kids. Yes. You can buy Golden Flagels. You can buy a Bugatti for like $6. Yes. And so, yeah, so there's huge prevalence of marketplaces where you can buy this stuff, and they're freely available, well, not freely available. And please, I did not say you go buy drugs, because if you get caught, I was not there. I did not tell you to go buy drugs. I'm telling you they're available. Don't go look for them. You may be caught. But yeah, so I know in Nairobi right now, a lot of kids are taking some of this stuff in the clubs. Yeah, so it's only a matter of time before you start seeing it a lot in your emergency departments. But essentially, as I mentioned, the effects, there are many effects that stimulate what we already know in terms of psychoactive substances. But the stimulants essentially include substances like the phenylamines, cathinones, aminoindens, too many words, and essentially they act on your dopamine or epinephrine serotonin receptors, resulting in a range of effects. So you have a lot of stimulants and hallucinogens, and we go through the different clinical presentations. So that's your stimulants, and then you still have your cannabinoid receptor agonists. And again, these ones give you similar effects to those of weed or THC, for those knowing, and yeah, they often list onto herbal products. So for the stimulants, well, the effects are all over. You have acute-term and long-term effects, as you can see. So that's your bath salts. So just American class. So when they say bath salts, I always thought it was those tablets you put in the dish, in the what's this thing called? Washing machine. Now I know it's something else. Yes, but anyway, bath salts, plant food, and as I said, so alertness, euphoria, paranoia. Reduced appetite, you get sympathomimetic activation, hypertension, tachycardia, coronary artery disease, so your cardiac effects are quite significant with this. Psychosis, seizures are kind of the long-term effects you get with these patients. Also, things like hypothermia, kind of long-term effects we'll see. Your cannabinoids, essentially they have fancy names. There's Spice, Noids, Black Mamba, or the Pandora's box. That should be fun. And short-term effects include things like panic attacks, agitation, cognitive impairment. You still also have cardiac issues like tachycardia, chest pain, nausea, vomiting, quite some of the key presentations we present. And of course, all of them again also have long-term effects. Interesting that they can be smoked. So cannabinoids can be smoked or inhaled as e-cigarettes, which is something that's getting common. The interesting part is that you can actually put these things in your rectum. So less commonly though, you can plug, that's a street term, you can plug a stimulant up your bum. Yep, so when you see your patients, yeah, look for these things. So the challenge, I guess, is first of all, we barely can test for normal drugs on the African continent. So now there is actually no standard testing for some of the new substances, and this is actually more of a global issue. It's very, very difficult to distinguish between MPS from other common substances in the emergency department. And of course, people do take more than one substance. So they'll have a lot of cannabinoid and alcohol. I know that happens a lot. So it's very hard to pinpoint the clinical picture. But so when this guy shows up in your emergency department, I like the weed here though. Yeah, it's quite cool. Yes, it's simple. I mean, I think it's not necessarily knowing what they took, but being able to stabilize them. Of course, your natural ABC. A good number of these people may need to be sedated if you can't talk them down. So priority one, try to talk them down. You may find there are a few reasonable ones. Then if that doesn't work, then get a few security guards and start popping some meds in them. So benzos will help for agitation and seizures. For hypothermia, cool them down as much and keep measuring the core temperature, not just the surface temperature. Especially for synthetic cathinones, you need to cool them. And then for your cardiovascular support, again, fluids for those who are dehydrated. Again, the hypothermia will cause a lot of dehydration, and beta blockers for tachycardia. So for me, this is the take-home slide. It's like the last slide. Yeah, so it's not necessarily, I mean, you should be aware when you have this patient come in and they're looking off and your lab is not really telling you what they've taken and you suspect, you just have drugs at the back of your head. Of course, rule out other organic causes, but have drugs at the back of your head and maybe some of this new stuff. But the approach is similar to most of these other ones, as there are not really any antidotes for some of these things. It's mainly supporting management and getting them up until the drugs kind of wear off their system. And that's it. Questions? If they're hard, ask an American who knows, who deals with this a lot. Any questions? Those on the continent, how many of you get a lot of drug overdoses? When I say drug, not your organophosphates, those ones are standard. When I say recreational drug overdoses in your departments, hands up. Malawi. How come you're not on that map? Yes. No, it's very, I mean, it's something that we don't see a lot of recreational drug overdose in our EDs. My suspicion is people can't afford to get that high. So, yeah, because it's not something, we see the poisoning from the organophosphates and the rest, but we rarely see your cocaine, heroin, rarely see that stuff. It's been taken, but I don't think they take it in enough quantities to end up in the ED. Good. Any questions? Going once, going twice. Are we still awake? I know it's post-lunch, so I may just be talking to myself. All right. Thank you very much.
Thank you. You know, I had a couple thoughts thinking about that that I was thinking about during the lecture. So, in the United States, we do have a big problem with synthetics, and one of the issues is that you know, once a substance is discovered, a lot of them come from China, and what they're doing is they'll change a small isomer because the United States would make the one they discovered illegal, and then they just change an isomer, so it's actually technically the new one is not illegal. There's another thing that's happening, something called Delta 8. Has anyone heard of Delta 8? Some of the Americans maybe? Yeah, so we are seeing, at least until recently, we'll see what happens in the next 4 years, but in the past 4 years we've been seeing more and more sort of legalization or certainly decriminalization of THC around the country. Where we live in Georgia, it's still not legal. However, there is something called Delta 8, which is, they've changed the Delta 8 isomer of THC, and therefore it's no longer THC, and you can actually buy it in the stores quite prolifically. And I can't speak from personal experience, but it supposedly has the same effects as THC. And but on the other hand, it's a little bit less predictable how it might affect different people because it is a synthetic. So just food for thought. So I think for our last session, we're going to have Gabriel come up, and Gabriel's a paramedic from Hennepin County in Minneapolis, and he's going to lead us in a simulation. He's going to tell you more about what he's going to do. Interesting fact about Gabriel, he's also an architect, which I found to be fascinating.
Give me a moment here. I like to say I can design your house and then save your life at the same time. So it's a little bit of an unusual combination. But as I mentioned, I'm Gabriel Keller, a paramedic with Hennepin County in Minneapolis, Minnesota. There's a group of us here that have been working with Dr. Mabula on helping improve pre-hospital care and help establish an EMS system here in ARUSHA in the future. But today we're going to talk a little bit about pre-hospital management of an MCI. So I think you just heard a great presentation before about how the global can be local and how things need to be changed. And we're going to start off talking about an event that happened where we live that was quite tragic and quite an event for us as an EMS system. And then go into start thinking ahead about the AFCON events that are going to be happening in this country in 2027. So this is now some years ago, 2007. There was a massive MCI in Minneapolis with a bridge collapse that was one of our major highways over the Mississippi River, a really major, large river that starts up in Minnesota. And this was not an event that we planned for. We've hosted the Super Bowl in Minneapolis, and that was something that took years of planning in case something went wrong. This was something that happened unexpectedly. Minneapolis, a little bit of similar size than ARUSHA, just to give you some context, but we are much more vertical and not as spread out. But around 3 million in our metro area of Minneapolis and St. Paul. We have around 30 ambulances in our fleet that covers some of that area, about 190 paramedics, but on that day we had 13 crews. Now, adjacent to us are many other services, and we all help each other out when big events happen or we're busy. And certainly in any major MCI, you need to reach out to your community partners around there for help. So a little bit of context, you can see downtown Minneapolis, the large buildings, HCMC, that's the name we use for our hospital. You see the Mississippi River running through it, and we have several bridges. So our cities are really bisected, are separated by the river. And so when one of those bridges falls, it really makes it difficult for us to move around the city as we normally would. And this bridge was the largest of those because it's where the major highway crossed that river. And the one that's the Stone Arch Bridge here is only for people to walk. So we really only had 2 other bridges to get across that major river during this event. The bridge itself, you think we're very well resourced in the United States. Bridges shouldn't fall down, and I think that's correct, but these problems happen everywhere. It was built in the 60s, it was steel, and it hadn't been designed correctly from the beginning, but nobody realized it, and it was rusting, and then they were actually fixing it, and there was additional weight on that bridge from construction that eventually was determined to have caused the failure. 140,000 cars cross that bridge every day, and this was around 6 p.m. that day that it happened. This was caught on camera, the bridge falling. So very many cars. And any MCI, it starts with people seeing the event or experiencing the event. And that first surge comes not from the calls come in for dispatch.
Okay, hold on. People are getting off the bus. Where am I now? Ma'am, I need to know where. Give me a cross street, okay? Give me a cross street to the bridge. Bus 911. Hi, the whole bridge, this side just collapsed between 4th Avenue and ARUSHA, Washington. 4th Avenue. Maya? I don't have that number. Every time I'll just There's a bridge collapse, Mariam. 35W over Washington. Well, it's between Washington and 4th Avenue. There's a lot of cars out in between Washington Avenue and 4th Avenue on the northeast of Minneapolis. 4th Street, okay. Stay on that. I got them going there while I had you on the phone. Okay. Stay on the line. Is there cars in the water? Yeah. Well, I can't tell. It's like in the water, and it looks like the cars are mostly still on the bridge. But there's a couple cars in the water. Do you have an emergency okay? Everything you got, the whole bridge over the river fell down. There's cars all over the place. Okay, where's the... I want to see 35 Avenue over the Mississippi, down by the U. What's going on again? Come on. There's hundreds of cars. Down the river. Like everything you got. Okay, sir, we're getting started, okay? Oh, hurry up. All right, sir.
Minneapolis 911.
They need watercraft in the river. There are cars sinking and people in
Yes, we
there.
know, ma'am. Everyone's on the way.
All right.
Thank you. This is 911. We said a hand call from this number?
No, it's going down on me. The bridge collapsed down in 35W.
Okay, we have a 11-minute call.
Okay.
Minneapolis 911.
Yes, I was on the bridge. It just collapsed.
Okay, are you
I'm
hurt?
in the middle. I'm not bad. I'm in the middle of the river.
You're in the middle of the river? Are you in a car?
Yeah, no, I'm out of the car.
Okay. Are you floating in the river then?
No, I'm on like a little island part in the middle. There's a lot of people here too, and I think there's going to be people trapped in cars is what I'm really worried about.
Yeah, we have help on the way. Have they gotten there yet?
I haven't seen anyone yet.
I don't know if you already said people down on the river road. But they're taking children off the bus.
701 Main Street.
It's down by the Red Cross. It's right underneath where the bridge collapsed.
Okay, well, we do have a response. Headed out.
Okay. Okay. Just wanted to make sure.
Hello?
Hi. Yeah, I'm on the bridge that collapsed. I'm in my car with people out here to get the door open, but I'm not moving because my back is in a lot of pain right now.
Okay, all right. So, all right, let me get help started to you here just one moment here. And you're on Main Street, right?
No, I don't know, 35W, the bridge collapsed.
Okay, all right. Hang on here. All right. How much are you in?
It's black, stop.
So you can hear the desperation, the panic in people's voices, both the dispatchers who are receiving those calls, right? Probably the first thought they had from that first call was that this was all a joke, a prank. But then the calls keep coming and they overwhelmed the system very quickly. So there's a lot of challenges here, right? This isn't something we planned for. It's not something we anticipated. And for EMS, from pre-hospital, it was really, we had difficulty understanding the scene. If you think about the size of it as it scales across that river, and there's many different levels on both sides, and to understand just the enormity of what was happening, and then the difficulty of accessing where all the patients were, and who was in the river, and who was on the deck, and who was high up, and who was low down. There's a school bus. And then maintaining command, that's difficult. That's something you practice again and again, no matter what system for responding to MCIs. There's some type of plan in place for who is in charge, and it changes very rapidly because the first people on scene may be a police officer, and often it's us. Our hospital's just a few blocks away, so we take charge initially, and very quickly on a scale like this, it goes up and up and up, and somebody else is taking command. So doing that and coordinating that was very difficult, challenging, and we learned a lot from it. Communications, that's always a challenge. Every time there's one, the cell phone towers got overwhelmed from so many people calling each other. I know at this moment I was at a dinner party and every one of our cell phones rang at the same time, and then very quickly we couldn't communicate anymore. The difficulty of having multiple staging sites, right? We needed to collect patients from both sides of the river and then get them to various hospitals, sometimes on the other side of the river. And then the hazards, there were so many hazards here, both drowning and the steel, things still falling, having to go up and down to get them. And the first response really, and you saw in some of those pictures, it wasn't us, it wasn't paramedics or police officers or firefighters, it was people there, people that hadn't been critically injured, helping people that were injured, or just people that had witnessed it and went to help. So initially, we started setting up some ambulances and very quickly set up a staging site and had our commander on scene. Our ambulances are all 4-digit codes, and quickly set up both operations on both sides of the river with many, many ambulances, both ours and ones we gathered from the surrounding communities. We also brought 3 doctors on scene that started to respond. I believe one actually went down to help some of the critical patients there. This is something we have in all our ambulances. This is our instructions, because I find as a paramedic, these don't happen every day. We're trained in this all the time, but to actually remember what that training is when you're a little panicked, because this is always a situation that's a little out of control, that's always chaotic, and especially something this big. But this lays out exactly who does what and when. So you can refer to that and really understand in a very simple form what to do. The dispatchers, they were not on scene, but certainly heroes of this situation, coordinating where everybody should go and what to do. And without a dispatch system that can handle that, it's really difficult to manage any scene at all. And that's all with the radio system that we have, and that was functioned quite well. The other thing we have, this was up and running then, we still use this, is a list of all the hospitals and their current capacity, how many beds they have open. So even prior to the event, this exists, it always is functioning, and we can see where dispatch can start determining where patients need to go, because we don't want to overwhelm just one hospital. So we were the closest hospital, but that doesn't mean we were going to take all the patients. I think this is a good, compelling picture to me. There's one responder, paramedic on scene. He's not our paramedic. I don't know where he's from. Their truck just must have been dropping somebody else off, and somehow they got assigned. Everybody else here is bystanders or people that were in some of those cars that weren't as critically injured. So everybody came and helped. This is another compelling photo, I think, for me. You see a woman who's partially clothed, holding an IV bag, a paramedic in brown, somebody that's from the hospital in scrubs, or maybe they stopped, I don't know. And then we have firefighters as well. So the difficulty is an FBI agent who certainly must have just self-dispatched there to assist. And crowds, they're always a challenge. They can be helpful, but also can hinder things quite significantly. So soon we had enormous response, right? We had enormous number of resources because we're blessed with that in the United States. So many fire trucks, so many ambulances. And slowly, or really in hindsight, rather quickly, within an hour the scene was well controlled and patients were really getting to the hospital very quickly. Not always in ambulances, right? We also used other vehicles that were there that had better access to get people out. I think this was a question in an earlier session today. Ben asked me, is transporters or ambulances better? And I said maybe it depends on the situation, but in this situation you need to use everything you can. So even with all our ambulances, here's 2 patients getting loaded onto somebody's truck to take them to the hospital. So there were injuries and casualties all over. Most of the deaths occurred on one side of the river. This is our little triage diagram in hindsight, right? We weren't tracking this there, but it was the difficulty of getting to people rather than the severity of their injuries that really was the biggest issue. EMS, we transported around 50 patients, I believe, most of them to our hospital at HCMC. It's the closest. We're the level 1 trauma center, so we're the best able to deal with the acutest critical patients. The University of Minnesota is the hospital that is closest to the other side of the river, so many of them were transported there. And then a handful to other hospitals. We don't want to overwhelm one hospital again. And then there's always walk-ins, right? A lot of people self-transported. More than half did. Interestingly, none of them self-transported to our hospital. They really went to hospitals that were further away. So this is remarkable, I think, in hindsight. I don't think it felt this way to the responders then, but from the collapse to the last patient transported was 2 hours and 6 minutes. An hour and a half after the collapse, their first responders had gone through every single car and every single area and identified where there were patients and where there weren't. So although there was chaos, there was a system in place from years of planning for some events that was able to be executed fairly well. About 13 people died, which seems remarkable, but everybody was inside a vehicle. I think that was a lot to do with it, and they were meant to protect us, not in this type of accident. But as that bridge collapsed, the shocks and springs in the cars took a lot of that force. And fortunately, we had no serious injuries to first responders, which I think is remarkable, because you want to rush in and you want to help. We're told to hold back, but it's hard. A school bus, that's a hard thing not to want to rush into. So there were minor injuries, but nothing else. So here I think you can see then by that night, really the scene was secure, the patients were transported, and now it was about recovery and recovery from building that bridge. So certain things worked well. I mentioned we had planned for things like this. There was a lot of civilians, bystanders that actually were quite helpful. The communication systems on our end worked quite well. We don't use cell phones very much for these type of critical situations. And it was next to many hospitals, right? If this had been further out, it would have been a much greater challenge. But we could improve things. There was too much chaos. We lost track of patients and where they were going, so family members were calling. We didn't have a system in place effectively at that time, so we could tell them, your daughter, your father went to this hospital at that time. And just speak a little bit about the hospital side of it. So it went out, there was actually a nurse was watching TV and saw, this is 9 minutes after the bridge, it was on the news. So she saw it happened. And then very quickly the hospital activated their MCI alert system, and they send out a page to, basically a text, pagers, to everybody saying, just get here now. So that had a huge response then of staff that weren't on scene. They didn't get patients, they had 30 minutes because it was difficult to get people out. So the first patient came at 6:40. So they had a 30-minute kind of head start there to get things. So there was this, I've seen it in place. They practice this, is it once, twice a year, Jen? Yeah, for these types of things. So very quickly, there's 4 team centers in the ED. One of them was cleared of patients and used as a triage area for everybody coming in. Everybody that could went straight upstairs, in the hallway upstairs. So there was really 26 beds cleared, and then all of our stabilization rooms, our 4 stab rooms, were cleared to allow for these patients to come. And this is the team getting ready. So Hennepin, we received 25 patients in 2 hours, which was fewer than anticipated. Some quite critical. 60% went upstairs. One was a DOA on arrival. But actually they had created an incredible capacity in the ICU because they pulled in so many staff. A lot of times we have rooms, but we don't have staff for them. So they were able to really move people around and had all those nurses and doctors come in because that page had gone out. We have a designated kind of command center for events like this that was then activated. So people knew their rules. This is something that had been trained. Things that didn't work, as I mentioned, the telephone systems, that didn't work well. People couldn't call in, call out. Runners were actually used, so physical people running communications within the hospital because some of the communications broke down there. So that was a way to, I think, a creative way to get around it. Some of the paging didn't work, and the Vocera system, I don't know if they have those here, but it's a way for people to talk to each other within the hospital, also went down. Other things, the charting systems didn't work well. It was hard to effectively communicate to the media. And there wasn't a good charting system, as I mentioned before, to kind of track these patients moving very, very quickly. So afterwards, you know, FEMA, which is our federal agency, disaster agency, they did an after-action report. So this is the opportunity that every event has, is for all of us, not just us in Minneapolis, but the whole world to learn from, is what are the things that went well that we want to replicate, what are the things that didn't go well, and as we think about new events, what can we take away from that? Now it's been some years, we have a new bridge, it lights up, it's quite beautiful. We have a memorial that remembers the people we lost from that. And we hope that that event, again, their loss, their tragic loss can prepare us for these future events. Which all of you then have this opportunity, as we here in ARUSHA, there's going to be a large stadium being built, a lot of people coming. It's going to be very exciting for the community and an opportunity to look ahead over the next 3 years to think about preparation and learning for that. Jen Dreyer is one of our disaster specialists, who's going to come up and talk a little bit about questions to ask and things to think about as you think about those events and that event coming forward.
Good afternoon, everyone. Like Gabe said, I'm Jen Dreyer. I'm a nurse in the emergency room at the hospital that he just showed in Minneapolis, Minnesota. I've been a nurse for 16 years. I've done a lot of disaster preparedness planning, whether it be hazmat, mass gathering, quite a bit. I'm on a federal government team that deploys for a few weeks to some of these disasters that happen as well. So that has kind of helped build that for me, build the knowledge. I get to talk about some of the planning stages for your AFCON 2027, which unfortunately some of the planning parts can be rather boring, so hopefully everyone stays awake for this part. It may seem like it's a ways ahead, but it's actually not that far ahead when you're talking about the mass amount of people that you have coming in and the fact that you get to build this stadium. Make sure this would be the perfect time to make sure that you're building it so that it holds the infrastructure and it's easy to get people in, get people out. You can kind of plan around disasters, expected disasters. There's a few similar events that they've had in mass crowds and things have gone really poorly. So one of your primary concerns are going to be stampedes of people, angry crowds, angry fans. What do you do with those angry people? Do they rush the field? Do you have to use tear gas to get them to go back? So these are just a few examples of some of the events in the past that have gone very poorly, and it just gives you kind of that hazardous vulnerability part where you can build around these things, avoiding these things. So some of the major risks, of course, that are going to be coming your way is that this is a 30,000 seat stadium. You're going to have a massive influx of visitors. What that looks like for your road infrastructure, what that looks like for your hospitals, your clinics, the excess traffic that you're going to have, all the needs that come along with the 30,000 extra people in your city. So part of the initial stages of planning are to just know your objective, right? To initially prevent or minimize the risk of injury or ill health and maximize safety, which in 3 simple words is keep everyone safe. Just in case anyone's sleeping. This is Minnesota. It's negative 16 degrees, in case anyone needed to feel warm. Okay, back to it. There are 4 stages of emergency management, which I know that someone else had kind of touched on, but you kind of are living in the 2 stages right now of the mitigation and preparedness. So you have a really great opportunity to hopefully prevent some of those big risks because you're building it as we speak. So the mitigation piece, of course, comes before the activity, the event, which primarily includes risk analysis, risk reduction, public education and awareness, and how to improve your infrastructure to maintain those extra 30,000 people. But you don't want to waste your time planning for every type of emergency possible. So you're going to do a risk analysis assessment. You kind of see what the probability of an incident is, what would the impact be, and then you plan around that. So you're not going to plan for a snowstorm in the middle of your event. You'd likely plan for massive rainfall or those types of things. Just in case anyone needed a photo of a dog today. He's sophisticated. So again, kind of the same slide from earlier, but mitigation and preparedness are where you're living right now. Preparing for the activities, this is your perfect opportunity for you guys to do drills, to have those phone conversations, to see what it's like to make all the phone calls to the hospitals, to say how many can you take right now. Make those phone calls and say, what's your ED capacity and how many can you immediately move out and get in, whether they be red, yellow, green. The preparedness part includes what equipment you have, having the equipment you need to accomplish those objectives. Training and exercise, plan the routes, practice the communication, train with the hospitals and clinics, with your EMS, with your fire, with your law enforcement, your traffic police. Early warning, understand and advance the major risks, focus on mitigation and training on that. So one of the major things that we do for large gathering events, sporting events, concerts, different large groups of people, is we create an incident action plan. It has all the information ahead of time so that everyone is on the same page at the same time, getting the same information. So for these events, you create the formal incident action plan kind of around what you have and what resources you have as far as EMS and law enforcement. What hospitals are in the area, you typically add a weather report on there, maps, so everyone knows which route to take. Do you plan a different route during this scenario to get to a hospital because the general population will be on the route that you would normally take? So we start with the forms. If anyone needs copies of the forms to develop this incident action plan, I put a little QR code on there if anyone wants. All the forms are there in blank and they're just PDF. You can fill them in. Don't want to put it down. Okay. Just a little more Minnesota for you. So some of the major communication failures, poor communication, discipline, right? Saying, I got it. You have what? You've completed the task. You understand the task. You know, you really have to use that closed loop communication. Duplication of effort. This is a nightmare when you have 3 people doing the exact same thing, 6 people doing the same thing. You want to delegate out tasks and figure out whose job is it to do what. Failing to follow the simple plan, right? The incident commander stays in the incident command and does a lot of the rules regulations piece. But when you put the incident commander into the situation, then you lose all control of the situation. Can you think of other ways that unplanned events could lead to extra work and chaos? And on that same note, how would things run if everybody had the same information? How would that help? Would the structure change, the organization, the efficiency? Would the transition from in the event, out of the event, and if anything happened? Removing any confusion, avoiding any duplicate efforts. So one of your main goals would be efficiency. Avoid every agency doing their own thing or doing the same thing. That's kind of how you lose all the forward motion of what you're trying to accomplish. Everyone should be working together to achieve the same goal. So I put together, well, I didn't, Jeremy Schaefer put together a incident action plan that's specific to the AFCON 2027. So all those forms that have the QR code from before, this is the actual incident action plan. And I'm going to show you some of the forms kind of filled out, but if you wanted a copy of this, it's in there. It has fake names, fake distances, so you'd have to change it to what meets your needs, but at least gets you the idea. Can anyone guess what slide is next? More Minnesota. Yay. Okay, so this is the cover page of an incident action plan. If you've already pulled up on your QR code, you see the, I can't remember, 17 or 18 page document this is. You have the option to print this off or just send it to each other digitally. Typically, these are done every operational period, and you get to decide whether that's 8 hours, 12 hours, 24 hours, and then you get a new or altered incident action plan based on that next operational period, because the night shift people aren't going to be doing the exact same thing as the day shift people, so it certainly will alter based on the time. And again, this is just so everyone has the same information on the same page at the same time. These are other forms within the IAP, the Incident Action Plan, kind of your goals, your objectives, how you're going to meet those objectives, your strategies, your tactics. How will you keep people safe in that environment? What does that mean for you? Does it mean building the doors big enough? Does it mean having an east-west entrance, exit? Having an emergency exit that a large vehicle or large vehicles could pull up to? Again, it just kind of goes through the objectives. Of course, number one would be ensure public safety and crowd management. And then you have to consider all the other things. I certainly won't read them off to you, but you have them in that document. It breaks down by branch division. You can know who's in charge that day, who's in charge of that operation, that 8-hour operational period, 12-hour. Everyone has the same person in charge with their phone number, their email. Their same contact, who's in charge of security, who's in charge of crowd control. If something happens and you're questioning it, you can all be reaching out to the same person as opposed to everyone doing their own thing. This is just kind of a broader view of it. Knowing what resources are assigned and attached to which person. So knowing the lead group for all of those, how many people they have under them. A really important thing I think that will come in handy for the AFCON 2027 is the radio communication plan. Know the leader in charge, know their WhatsApp, make a group, connect every 8 hours, every 12 hours, whatever you decide. Communicate with each other what the problems are that continue to go on. Are you seeing a lot of these weapons be confiscated? Are you seeing a lot of X, Y, and Z things happen? The more you can talk to each other and communicate, the better you can plan and strategize for the next. So this is just kind of a tempo, if you wanted to say, like, in the morning we're going to do this, we're going to do a briefing, then the general command staff will brief, you can talk about a tactics meeting. Again, it's just kind of a layout of how you choose to build your day out. What I think is one of the most important plans, but maybe because I'm a nurse, is to have the medical plan. Know exactly which route you're going to take out of that stadium, who's going to pick them up, who's going to take them to which hospital, how far is that hospital, what injuries are there currently that you may need to manage before that 20-minute transport time. And then also knowing, did you just send 15 people to this hospital, have a plan for the next hospital that you would be starting to send patients to. So a lot of times we do aerial maps. The plus signs are hospitals. The big yellow circle is going to be where the stadium is. And so far, what I can tell from this far out view is that there's not any health care any closer than a 20-minute drive, which the 20-minute drive is likely on a good day and not on a day when you have that many extra people in your area. On top of the maps, you'll have map routes. So these can all go in the back. And then it's easy when someone says, hey, where should I take this person? Refer to page 14, you're going to take that route, you're going to go to that hospital. Everything should be pre-planned. Not that things won't go not according to planned, but it's nice to have it laid out. Easy to share that information. And then, of course, it's nice to know your weather. Are you going to have a big rainfall? Is it going to be hot? Is it going to be so hot that you really need to be concerned about weather emergencies? Just having that overall concept of understanding. And then a happy video. Maybe. Or just a nice skating child. There. Have a plan so you don't fall down. Thank you. This is the QR code one more time in case anybody wanted it for the paperwork for the incident action plan. Good luck to you guys with the 2027 AFCON. Hopefully I can come back for that.
That's our presentation. We just want to thank everybody for joining us, and hopefully kind of us highlighting what happened and starting to prompt some of these questions will be helpful. So thank you all, and thanks for a great conference.
didn't know it's too loud. Okay, good afternoon once again. It's a pleasure for me to be here once more. I was here yesterday. As we are approaching the beginning of the preparation of the coming ARUSHA Emergency Medicine Conference, the next ARUSHA Emergency Medicine Conference, I would like to thank everyone for the attendance, for the oral presentations that we sent, the posters, and more importantly, your presence, your physical presence. The organizing committee would like to say asante sana for the people who are from Tanzania, Kenya, Uganda. Could I see the hands of the people? Yes. Asante sana for the French-speaking, the francophones. Merci beaucoup. The ones from Cyprus, Teshakil. The ones from Spanish-speaking countries, gracias. The ones from Tanzania, but from another origin, shukriya. Okay. For the German-speaking, danke schön. The Aussies, thank you very much. Malawi, Ziko Mokwambiri, Mama Mulinda, you around? She's not here. The Shonas, Tinoenda, Tinotenda. The ones from Eswatini and the nearby countries, Giabonga. You here? Thank you, Mama. For the rest of the guys speaking English, US. Thank you very much. Yeah, you're from US too. Thank you very much. Ali, how would you say thank you in your mother tongue? Wabeja. Wabeja sana Ali. Okay, so I should also be grateful for the fact that we had supporters and sponsors from everywhere. And I hereby would like to call the SQF director. I would ask the SQF director, Dr. Mabula, to come and present tokens of appreciation to number 1, BSV. A representative from BSV, please. And this conference has been very generous. Everyone who's presented in any way has, in some form of, gifts, received something. So BSV, any representative from BSV? Yes, there he is. Thank you very much. A round of applause. The next will be EM Cure. EM Cure. We enjoyed their support in many forms. Thank you very much. Next will be EMAT, the Emergency Medicine Association of Tanzania. EMAT. Yes, EMAT. Thank you very much for the support. Then we have those who presented without talking. They prepared the presentations. They made sure that we also took part in reading and understanding their work, the poster presenters. So I'll call them by the first authors, the ones that appear in the posters. I'll call them up here, and wherever they are, could they please come and receive. So number 1 is Rosalia Njau. Rosalia Njau. Yes, there she is. Thank you, Rosalia. Then Jesse Abelson. Jesse, wait, he's in Serengeti. And don't forget to go, to places. Tanzania is more than just Arusha. And it's more than just the Arusha Emergency Medicine Conference, okay? So wherever Jesse is, tell him that we read his work, and he has his token here. Is there any representative who can take his position? No? Yes? Okay. Then Lior Levinstein. They're also in Serengeti. They're probably flying using the air balloons now. Okay? Just a fact, the Serengeti is the setting for the Lion King. It's an extension of the Masai Mara from Kenya to Tanzania. So those watching Simba, Mufasa, Pumbaa, the setting is the Serengeti. Okay? Then the next is Adeline Dozwa. Adeline. Is Forrest Turner here? Forrest Turner? Okay. I somehow figured out that Forrest is not here, but Adeline is the second in the order of authors. Thank you very much, Adeline. Then is Katende around? Katende? Great. Your first name? A. Katende. Great. Thank you very much. So to the organizing committee, we ride on your support, and this conference has been very successful because you came for us. And at this juncture, I would like to then welcome Dr. Mabula, who is the SQF director, to give a vote of thanks.
Oof. Yeah, good afternoon. As we come to the close of this incredible conference, I just want to take a moment to thank each and every one of you for being part of this experience. It has been a pleasure to engage with so many talented individuals and thought leaders, all of whom brought valuable insights and perspectives to the table. The conversations we have had over the past few days have been inspiring and thought-provoking, and I am confident that the connections made and knowledge shared here have a lasting impact on all of us. I encourage everyone to take what you have learned, apply it in your work, and continue to reach out to one another to build the networks we have already started. A special thank you to our speakers. They did an incredible job. The panelists, the organizing committee, our supporters and sponsors for making this event a success. And of course, to all the participants, because without them, this couldn't have been the way it has been. So your involvement had made this event truly special. I wish you all the best moving forward and hope to see you all again in 2027. Again, 2027 for the ARUSHA Emergency Medicine Conference, as we start the preparation and planning for it from today. In the meantime, AFSEM 2026 is coming our way, will be hosted here in Tanzania for the first time ever. And so with that reason in our mind, the ARUSHA Emergency Medicine Conference, we have been moved to 2027 so that we can work hand in hand, shoulder by EMAT, to make AFSEM 2026 a success. And so on my behalf and on behalf of the local organizing committee and on behalf of the SKF Board of Directors, I wish you all a safe travels, and thank you once again for being part of this event this year. God bless you.
So as usual, we have our evening tea and some time to network. So don't forget to, take them business cards, numbers, emails, okay? Because that's also part of these events. So tea is ready for the ones going for safaris, safe safaris. For the ones traveling back home, safe travels.
Hongera sana mtazamaji wa SKF TV kwa kuchagua na kutazama matangazo ambayo yanarushwa live kupitia YouTube yetu channel kama SKF TV, kwa kuungana na sisi kutokea hapa Grand Melia kwa ajili ya conference ambayo ilianza kuanzia tarehe 10 hadi leo tumetamatisha tarehe 14 ya mwezi huu wa pili. Na kushukuru sana kwa wewe ambao ulihudhuria kuja kushiriki katika mafunzo haya ya huduma ya dharura. Watu wengi kwa kweli walitokeza kutokea nchi mbalimbali na mikoa mbalimbali kuja kujishiriki katika mafunzo haya. Lakini pia nishukuru timu nzima ya SKF TV kwa kufanikisha jambo hili kutamatika vizuri sana. Nikwambie tu usipoe wala sisi hatuboi, basi tutaendelea na matangazo yetu vivyo vilivyo kuanzia siku ya Jumatatu. Tutaendelea na shughuli zetu. Nikutakia wakati mwema na ninakushukuru sana kuchagua SKF TV, lakini pia endelea kusubscribe na kulike na kucomment kila ambacho tumekifanya hapa Green Media, ukitoa mawazo yako na comment ili next time tujaribu kurekebisha pale ambapo tumekosea. Tunakupenda sana. Mimi hapa ninaitwa Pendo Gotoni, fundi mitambo alikuwepo Panta leo Lugusha. Nikutakie wakati mwema.